All right. A couple of keywords will definitely summarize my cases today. Cysts, lymphocytes, plasma cells, protein. So here is a first patient. Let me actually show you non-MIPS images going back to 2008. There is a combination of multifocal, multilobar cystic lesions. The cysts have thin walls, but some of them clearly contain residual foci of tissue within that look like septations. For example, this one here in the left upper lobe. And you'll see that nodular opacities are present in the lungs as well, many of them in very close proximity to the cystic lesions. And they are pretty much everywhere. Here's one that's quite large in the anterior medial right middle lobe, and more of the same. So this was biopsied. Let me show you a couple of images from an exam that has thin cuts, just to give you another feel for what these look like. So they are increasing in size, and the nodules are getting a little bigger. And some, for example, down here in the right lower lobe are also calcified or ossified in part, as you can see there. This one too. Here is a PET. And I will tell you that this was some years later, at which time an ovarian cancer was diagnosed. So what you see there is not related to the lung disease, because the lung disease hasn't produced any symptoms and is not being treated as such. So we see that some of the lesions are associated with FDG avidity, and the lung biopsy that you see there, CT guided, resulted in amyloid. So this is a nice example of the presence of cystic lung disease consequent on protein deposition. And the protein is amyloid, but not otherwise, I don't think, evaluated in terms of the substrate of the amyloid, but Congo red was positive. So usually when I see that, particularly if it's an incidental finding in an older person, the first thing I typically think of is Sjogren syndrome. And she does not carry that diagnosis. I can see here that she's being seen by a neurologist for Parkinson's disease, but I was looking anywhere for dry eyes or dry mouth, but I didn't find that. But otherwise, that's typically what I think of when I see these imaging findings. So a very nice example of cystic disease and amyloid. So let me show you the next one. Here is a patient that was imaged for the abdomen, and a finding that was identified and noted in the abdominal imaging report is this nodular opacity here, which is small. It's located in the right middle lobe. No other comments were made about the lungs on the CT report. As you can see here in the lower lung zones, there are, in addition to that small nodule, cysts as well. And here's another one. And let me bring up a chest that was subsequently done, or this is the one that was subsequently done. And you'll see that there are cysts in various locations, small ones here in the right upper lobe. Here's a nice big one, also with internal tissue and septations within, so in multiple places. You can see here that a CT-guided biopsy of the nodule was performed subsequently. Here is the pathology report on it. So that nodule is basically plasma cells, described as a plasmacytoma, but it's a focal collection of plasma cells. And there's no amyloid as such, but it is a plasmacytoma. Oh, it says with localized amyloidosis. Excuse me. So there's no findings of systemic amyloidosis. Right there, kappa restricted. So the complex of findings here again is very nice. We have plasma cells, kappa restricted, deposition of protein, at least with respect to the nodule. And then the cystic lesions elsewhere in the lungs demonstrate that plasma cells have been proliferating elsewhere and depositing protein. It's interesting here to me that they decided to treat that small lesion with radiation therapy. I think if it was me, I would just probably leave it alone and watch it. But there's a nice correlation between what we see in the imaging and that plasma cell, small plasma cell lesion. So let me show you another one. And by pure chance, I have a number of these that just came up, but these are really nice examples. So let me start this one off by showing you two frontal projections of the chest. And I'll put them alongside. And the time here is March of 13, September of 2018. And notice that we have these focal non-segmental opacities in 2013 in the upper lung zones. And you can see what's happened to them over time. They are larger, but in bringing this one up, you can also appreciate that they are now large air-containing cystic spaces within those opacities. So let me show you a couple of representative images. So the radiograph is 2013. The CT here is 2014. I'm going to try and make that not do that. And bring up a CT. The most recent one will be this one. So again, 2014 here, the CT, and 2018. So in the lungs, we have, again, a few cystic spaces in 2014, but we also have those focal opacities in the upper lobes at that time, within which there are patent airways. And in relation to some of these patent airways, they are slightly dilated. And for example, this one may also be a small area of cystic change that may be separate from the bronchus within those lesions back then. Now let's look at the lesions now. You'll see that indeed large areas of cystic change have developed within the lesions. And these foci of bronchiectasis and cystic change in the right upper lobe lesion have increased pretty substantially over time. So multifocal lesions with dramatic cystic change developing in them. Another interesting finding from the more recent one is, let's see if this is the patient I'm thinking of. Oh yeah, there we go. So let me make this not scroll, and then I will show you that. A new lesion that has developed over time in the upper abdomen is this lesion near the kidney, and that on PET is FDG avid. So here is the pathology on both this lesion in the abdomen as well as the parenchymal disease. So the patient started off many years ago with a MGUS IgG kappa, and over time and recently she was diagnosed by virtue of a biopsy with a MALT lymphoma. So additional information about the endoscopy and biopsy of this lesion, as well as a transbronchial biopsy of a right upper lobe lesion. Both showed marginal zone lymphoma. So this is a terrific example of the evolution of a marginal zone lymphoma over time, and a nice demonstration of this phenomenon where you have deposition of protein, and the culmination of it is the formation of cystic spaces as matrix metalloproteinases are responsible for degradation of extracellular matrix. And I'm really impressed by how much cystic change as well as bronchiectasis has developed within the upper lobe lesions. This is probably one of the nicest examples I've seen of that phenomenon, where one can easily explain this knowing the pathology. What you see there. Okay. Okay, this is also an interesting case of a patient that developed opacities in the lungs, which are new from 2016. Let me see, make sure I got the right patient. And at that point in time, he developed opacities in his lungs that looked like this. So there is non-segmental opacity, poorly marginated with adjacent lung, but traversed by patent airways. And it's multifocal, so at that time in the left upper lobe and in the posterior right lower lobe. A more recent scan shows that these are waxing and waning. So the most recent CT shows that some of these have resolved. So where that was, we have just a little opacity. And more recently, this has evolved in the right lung. So now we have more opacity, particularly in the superior segment of right lower lobe, but otherwise diminishing opacities elsewhere, perhaps leaving a little bit of scarring. So the interesting thing about this patient more recently is that at a point in time, he was noted to have a enlarged lymph node in the left side of his neck. And he's received steroids intermittently. The last time he had it was in December, but I don't know what else he's had. But a biopsy of that lymph node showed findings consistent with a lymphoproliferative disorder with increased IgG4 positive plasma cells. So very consistent with that. And here you see the pathology report of the right lower lobe lesion, also consistent with IgG4 related pulmonary disease. So a lymphoplasmacytic infiltrative process, very consistent with the imaging findings we see on CT, and then other immunohistochemical findings, very consistent with IgG4 related pulmonary disease. So he has it in the neck node and he has it in the lungs. It's another nice example of IgG4 related sclerosing disease, at least involving those two things. So really interesting cases we've had recently of different lymphoproliferations, this being a IgG4 related disease. Is David on?
Yes, Howard, these are beautiful cases. Remind me it's not safe to travel to Utah because you get these bad diagnoses. So I will stay in my state.
All right.
Very nice.
So just by chance, we had some really nice, interesting lymphocytes, protein, and those kind of cases.
Yep.
All right, Jeff, those are mine.
All righty. David, are you ready or do you want me to go?
I have a couple.
All right.
So here's a young woman with an abnormal röntgenogram. Can you see the röntgenogram?
Yep.
He has this mediastinal mass here, and it's adjacent to the aorta, and behind it is another mass-like thing. And on lateral view, we can see that it corresponds to a very big left pulmonary artery. So this woman she has a history. She's from the Philippines. She's not had any treatment, but she has a history of coarctation of the aorta and also rheumatic heart disease. So that's the history we're dealing with. She did get a CT scan, and she indeed has a huge main pulmonary artery, and the enlargement extends into left pulmonary artery. Right pulmonary artery is modestly enlarged proximally, she's got a very large right atrium and right ventricle, and she has mitral stenosis here. I think you can see a jet of blood here from her mitral stenosis, and her tricuspid. So her tricuspid valve is thick, doesn't open all the way, and she's got all this hypertrophy, I think, of her infundibulum, and then very thickened pulmonic valve as well. So the question was on echo whether she had congenital disease of the pulmonary valve or whether this was all rheumatic disease. The one valve that was spared was her aortic valve. She went to surgery and she had tricuspid, pulmonic, and mitral valve replacements. And the pathology indicated, based on thickening and hypervascularization, that this was rheumatic disease of all three valves. So rather an unusual pattern of rheumatic valvular disease because of the involvement of the pulmonic valve, which is the one that's usually spared, and the sparing of her aortic valve. And by the way, on imaging, when the cardiologist examined her CT scans and all, determined she does not have coarctation. Her aorta looks just fine. So very dramatic, untreated rheumatic heart disease, and the unusual feature here is the pulmonic involvement. On echo, she had pulmonic stenosis and regurgitation. I think the regurgitation helps with the incredible enlargement of the main and left pulmonary arteries. So with regurg, you get, with a volume overload, you get often more dramatic dilation than you do with just a pressure overload. She had both. Okay. So not normal chest radiograph. And then here's a woman. So I saw this case shortly after seeing a case of azygous continuation. The previous case reading out the night resident one morning this week was a case I've shown before of azygous continuation in the setting of situs ambiguous and liver transplantation. So the previous case to this is one I've shown you guys, and that had nice azygous dilation. And then the next case showed this case here with a very nice aortic nipple. This is a sickle cell patient who's had lots of venous thrombosis problem, and you can see that she has a venous stent in place because of her thromboses. And over the years, she has dilated her left superior intercostal vein, which is the left-sided equivalent of an azygous arch. So here's her very dilated left superior intercostal vein, and she also has a dilated azygous vein on the other side. This was not as visible on her imaging. So we've got these parallel channels here, dilated left superior intercostal vein, which connects to accessory hemiazygous posteriorly, azygous vein connecting here, all because of venous thrombosis. You can see all the collateralization subcutaneously and everything because of her venous thrombosis from her sickle cell disease and her chronic catheters in place. So a very nice example of the aortic nipple dilation of left superior intercostal vein.
Very nice.
And then there's this man who is a Buddhist priest, an abbot of a monastery in British Columbia, and he developed a bad headache and was admitted to a hospital in British Columbia, and then was transferred down here. And he has this diffuse lung disease. So he had, by this time, he was having difficulty breathing. He was short of breath. He had a really bad headache, and had this set of radiographs with, including some pleural effusion. I don't know how much hydration he'd been given at this point. And he was hyponatremic on their initial lab workup. I don't know what his white count was. And this is what his chest CT looked like, with a lot of ground glass on both sides, much worse on the right than the left. Lowish volume here and bilateral pleural effusion. So let's see if this image is any sharper here. So ground glass merging into denser consolidation, particularly in the right lower lobe, accompanying pleural effusions, a little bit of pericardial effusion too here, probably. So this turns out to be Legionella. His urine antigen was positive. This is Legionella Pneumophila type 1 or serotype 1, whatever it is. And his history was interesting. Before he got sick, on the grounds they had an obstructed septic system, and so they had dug out their septic system, and so he was exposed to standing water. So because of this plumbing problem that they were having, he had water exposure, and shortly after that came down with his headache and then his cough. But the headache was profound, and that's a very good finding for Legionella as well as mycoplasma pneumonia. Often that and nausea and abdominal pain are often the way these atypical pneumonias present. Both mycoplasma and Legionella can present with systemic findings of headache and abdominal pain and nausea and things like that. And hyponatremia evidently also goes with the Legionella. I'm quite sure what the mechanism is. So this was Legionella. So a cause of diffuse pneumonia, very dramatic. So Legionella is one of the organisms to consider when somebody presents with bilateral lung consolidation. So most pneumonias more commonly will present with localization to one lobe or something like that. So a multilobar pneumonia at presentation is a good finding for Legionella. It's often a ground glassy pneumonia that makes you think of viral infection or pneumocystis. It can be dense as well. It can form lung abscesses, so it can be cavitary. It does a variety of things, but most of the cases I've seen have been diffuse and low grade like this, with mostly a ground glass abnormality. And that's a common presentation of Legionella. I'm not sure how to explain the pleural effusions. I don't know whether he'd had hydration to cause those or what. So he recovered and he got better, and then he had this follow-up radiograph. This week is what brought him to my attention, and I then found those earlier radiographs this week. So you can see that he's almost completely clear. There might be just a little bit of scar in this right upper lobe. So a clean living man, no bad habits, a Buddhist monk and the abbot of this monastery, and he was exposed to water from this problem in digging up their clogged septic system. So
very nice. David, can you leave this one up and put that initial radiograph alongside it when he had the consolidation next door to it? Yeah, I think if you look at the right-hand side, thinking about overhydration, he definitely weighed more on the right-hand side than the left-hand side. He's got tremendous generalized subcutaneous soft tissue edema. So I think they probably did give him a lot of fluids. He's got a lot of extracellular, extravascular water in his chest. So the thought of pleural fluid goes along very nicely with that too.
And his vascular pedicle is also wider on the original one, around the azygos particularly.
Yeah, expanded intravascular blood volume is probably present, perhaps.
Do you think he's got some anasarca going down here?
Not that impressed with, yeah.
There does seem to be some stranding in the fat there.
Maybe the hyponatremia had something to do with that.
Yeah.
Yeah, he's got a little bit. But it sure looks different, doesn't it? In a short period of time, the thickness of the soft tissues is dramatically different, even bedside versus not.
Right. Okay.
All right.
Very nice.
Well, let's see. Well, I'll start with this case then. So this is a case of Legionella, but this is a different patient. This is a kidney transplant recipient, and this is a portable, but we have bilateral lung opacities. This one looks more like a nodule. This is more amorphous consolidation and some hazy stuff around there. Extrapleural fat, but immune compromised. And but when you look at the CT scan, which is just a few days before, it was done a few days before, this is a totally different appearance. And this is Legionella Pneumophila. This is not one of the other species that we've seen, but it's a nodule with a halo sign. So when you look at this, you'd be a great example for angioinvasive fungus, maybe cardia. And he's got denser consolidation down here, which would if he aspirated or if that's all related to, I'm guessing it's all related to Legionella. But I checked all the fungal markers and everything was normal. They brought him pretty well. So this is all Legionella. And I came across this case because I read the follow-up, and it's all gone with appropriate antibiotic therapy. But I thought this was a neat case because I've not seen the more community-acquired version of Legionella look like halo signs.
This definitely looks like McDadii. So McDadii is the classic one for giving away fungal-looking nodule with a nice halo, but it grows faster than it comes on faster than fungus.
Right.
So a super fast fungus is often McDadii. I've seen one case of Pneumophila that had this, and this is the second case now.
Yep.
With that McDadii pattern.
And they confirmed the species and everything. Yeah, that's when I looked at this. That was my first question when I saw Legionella was it McDadii or not? Because I have a couple cases, and you've shown some that look like a big halo sign. But it's
Very interesting.
Yeah.
Oh.
Okay, well, this is kind of a cool case. I wish I had a radiograph, but I don't. And this was incidentally detected. I can't remember why. I think it was on an abdominal CT, but subsequently got a chest CT. This is a young woman in her 30s who has this mass in the right cardiophrenic fat. At this age, we would think of maybe a germ cell tumor, maybe lymphoma. She's kind of on the young side for thymoma, doesn't have any myasthenia, but this is a solid mass. It's very homogeneous, so it doesn't quite look like anything. So you'd still have to, I think, consider a thymoma or maybe a sarcoma in this place. She was asymptomatic. And so they went in and resected this thing, knowing it wasn't going to be lymphoma, presumably. Or I can't remember if they biopsied it. And no, maybe they biopsied it but didn't see. It wasn't lymphoma, but no one was sure what it was. So they went and took it out, and it was an uneventful VATS resection, no complications. But it was odd because the path was sitting for several weeks. I was just trying to figure out why is it taking them so long, because I figured it was going to come back as some weird thing. And this ended up being an inflammatory myofibroblastic tumor. So they were doing a bunch of rearrangements and stuff. And, we've seen them in the lungs. I don't recall seeing one in the mediastinum. I'm sure we've probably encountered one on here, but you can add that to your list of cardiophrenic masses. But in this case, I guess there's now some gene rearrangements they can do for it, but there's nothing left of it. There's nothing really to treat at this point. I've seen some that have regressed on steroids and popped up elsewhere.
Did it have a lot of malignant features? Do you perhaps know?
I did not. It just talked about like the stromal stuff and a bunch of genes I'd never heard of.
So Jeff, was this then mediastinal? I mean, it's got a very sharp.
You can see it's in the mediastinal fat here.
Uh-huh.
Yeah, I mean, I would have had to bet on thymoma, even though she's 30-something, because it just doesn't look like lymphoma. It's not thymic tissue. Here's our normal thymus here, and it's not a germ cell tumor. It just didn't have the right look. And in females, they're usually teratoma, so we expect to see some fat or something. And sort of an incidental finding. So they took it out, and she's doing okay. So just a weird.
I've not seen one before in the mediastinum, although the lesion itself is something that is seen in a variety of very strange places and organs, I believe.
Yeah. So I don't know what tissue it arose from down there. There's not much down there except pericardium and lymph nodes. So I don't know. But apparently pathologic evaluation is a lot more complex now. And that's why, it took a long time to get final path back. This is a cool case that Chris Meyer shared with us. This is a transgender patient. So is now is identifying as female, and you can see here's the radiograph. And the reason I'm showing the radiograph, if I can get it, is this is an energy subtraction, dual energy. So these are the bone calcium images, and you can see there's this really dense material in the soft tissue of the breast. And then I've got and that's from a year before, but I've got a CT now that shows this very amorphous thickening of these calcifications in the subcutaneous tissue. So this is free silicone or silicone injections for cosmetic purposes. I know we've seen cases here from cosmetic surgery done elsewhere where these can get really bad and lumpy, and even see it in uptake in the axillary lymph nodes. But just in the chest wall here, Looks like they have an infection or something at this point, but that's not why I saved the case. But I thought the dual energy was kind of cool because when we see breast implants on these, the silicone implants are really dark on the dual energy, whereas the saline ones are not. They disappear. If you go to the lateral, you can, if you window it just enough, and I'll blow it up, you can see there's clearly sort of nodular dense tissue in the breast.
Gosh.
Okay. I've got two cases. I was inspired by these because I finally downloaded Seth's case of this, or found it in my files. These are two aortic dissections, type A, with prolapse of the dissection flaps through the aortic valves. And so just a pretty classic type A, but it's really cool down here. You can see it going, the flap going through the valve plane. And then I've got the echo images, which I can play. And we can see on the valve here, there's this stuff floating around. Let me get a better plane here. There we go. Whoops. You can see this extra little flap. The other one I think has a better echo. But this is just, we just happened to found another case of it, of these. But here's another one. They kind of look the same. They have this sort of double barrel appearance to it as opposed to a single flap. And there we have this bunched up flap, and then we got a little bit of motion, but you can see it going right through the valve plane. And then on Cine, you can really see if it'll load. Come on. There we go. You see the little flap coming through the plane here. So we're sort of in a transverse plane, but I thought that was kind of cool to see that. But Seth had shown in one of these, so I don't know what the proper name is, if it's like a windsock aorta, but both of these, very similar appearance.
Jeff, before you go, can you show the first one, the aorta, and let's see if we have circumferential flap with so-called intersusception, where you have prolapse of flap through the valve, but also the distal flap going distally in the aorta.
Yeah, it just kind of stops right at the cruce. That's as far as this was imaged. So here it looks just more like a conventional dissection.
In the ascending aorta, is there a portion where there's no flap visible at all?
I don't believe so.
Not entirely.
No, you see a little break in the flap here, but not really. It just kind of dissected down there. And then you just see it going in. This one goes right to the coronary ostium, but doesn't get into there. Now, the aortic root is dilated here too, so I don't know if there's some pre-existing. And this one, the right coronary is small, so it looks like a left dominant system, but it also goes to the ostium, but not through it. And there's the valve plane right here. You put on a coronal too.
Very interesting. So it's sort of intersecting backwards.
Yeah. Just poking through right here. All right. Now this is a cool case, and I'll show it in the order that it was presented to me because this was a transfer patient. So this is a younger patient. I think he's in his 40s. I wrote it down, or maybe 50. He's 47. Has a history of asthma, and his local physician, apparently he self-medicates with prednisone when he gets flares. His local physician would give him a lot of prednisone. He'd been becoming more short of breath and taking more prednisone. And you can see they did a chest CT at an outside hospital. It shows diffuse lung edema, pleural effusion. But he also has, did I say this off? I'm going to say soft tissues, but he's got a small pericardial effusion as well. Heart size is normal, and then he's got some more dependent consolidation in the lower lobes, whether or not that's something else, and just a lot of engorged lymphatic tissue. So it looks like a little almost tracheal bronchus-like variant, but looks like diffuse lung edema. An echocardiogram there showed the pericardial effusion, but relatively normal function. But he does have a very high peripheral eosinophilia. So there was some concern for, and then there's this question of a chronic eosinophilic syndrome. So he got a cardiac MR that was being done as we were looking at the CT, so I was able to look at some of it and then loaded the whole case. I'm going to have Brad, my fellow, show it because he's better at this than I am. So he'll show it.
Where is it on here?
Yeah, just grab it and drag it over. You can scroll down and change the series.
Yeah.
So I think
If you want to send it, just hit the space bar.
so. Just looking at it, looking at the short axis SSFPs here, you can see the pericardial effusion, and the function's a little bit down. I can't remember what we got the EF at on this one, but it was reduced. He also had an elevated troponin and a clean cath before they got the MR. And then our T2 weighted sequence here shows these aren't the best quality images, but there is suggestion of some myocardial edema here in the anterior lateral wall, anterior septum. And then down towards the apex here, maybe affecting the kind of anterior wall, anterior septum as well. And then on the let's find the late enhancement here. So phase sensitive, these were single shot phase sensitive inversion recovery images, and the jet black shows the large pericardial effusion or moderate pericardial effusion. And then as you work down from base to apex, you see some subendocardial delayed enhancement, and it's actually sort of patchy in various spots, maybe a little bit more mesocardial towards the apex. I think there's another segmented acquisition here that shows it even better. So those are maybe a little bit clearer, but you have kind of this mixed, patchy, relatively low intensity delayed enhancement, some of which is subendocardial, and some of it's more mid-myocardial. And then we also did, just for fun, if I can find it. So there is, I'm looking for the T1 mapping images here. I think this is it, actually. So we did T1 mapping on this patient, which looks pretty good for eosinophilic myocarditis.
So yeah, he's going to get a workup for hypereosinophilic syndrome and see if this is a clonal problem or if this is just something else there. But pretty impressive case.
Very interesting.
How about, was EGPA a consideration in him? Does he have sinusitis or neuropathy to go along with
Not, there was nothing else mentioned that, just asthma.
It's a
neurologic, no signs.
So Jeff, was he getting steroids at the time that he had that eosinophilia?
He was self-medicating, so he was taking them as needed, which means he wasn't on continuous high dose.
That's pretty impressive if you have an eosinophilia despite some corticosteroid.
Yeah, that's why they're worried about a clonal expansion of it.
Okay, keep us posted on this case.
Yeah, it's on our list to follow. All right. Well, I was hoping Seth or Travis would be on to add any commentary on that because I don't know much about it. But because I thought with the septal lines, you can see that with EGPA in the lungs, but it makes you wonder if that is a reflecting more of cardiac involvement because it looks just like a heart failure.
Yeah.
So,
well, I mean, so EGPA, a lot of the people die of the myocardial disease. So I think this all fits nicely with EGPA so far.
Yeah. Yeah, the ATS is doing a webinar in January on EGPA. It's like a 1 hour thing. So I put it on my calendar. If I'm free, I'm going to listen in on it, see if I learn anything new about it. All right, well, that's what I have for this week. So I guess we'll end a little bit early, but thanks, everybody.
I've got 2 more cases I could show.
Oh, yeah, that would be great.
All right.
So Jeff, what about the next couple of weeks? What do you want to do for over the holidays?
I'm available this next Thursday if people are around. I'm going to be gone the following Thursday.
Howard, what about you?
I'm around. I'm around.
David?
Yeah, well, I'll be here. I might not be able to present cases the week following, but I will be here next week. So why don't we plan on next week?
Okay, and then we'll touch base for the following week if we're around.
Perfect.
All right.
Okay. All right. This is an interesting patient. This image shows that she was symptomatic quite recently because of a pneumothorax. There is not only pleural air, but there's also pleural fluid. So one can make a diagnosis quite readily of hydropneumothorax and wonder why it might be present. And I will now show you the context of this, because this is a secondary spontaneous pneumothorax. So let's go back to early November, and I'll scroll through the lungs, and you will see that she has multifocal, multilobar cystic lesions. Some of them, in some locations, have thin walls, but some do not. And some of them are also surrounded by some ill-defined opacity, as you can see there. So here is a cystic space with an apparently thick wall and a little septation within it and a little ground glass halo around it. Here is another cystic space. Here is another lesion.
Okay.
So this patient does have a history of a post-auricular cutaneous angiosarcoma. So these imaging findings are very consistent with the cystic lesions of metastatic angiosarcoma of skin. And undoubtedly one of these cystic lesions, perhaps this one that's really close to the pleural space, disrupted the visceral pleura, resulting in pneumothorax. The last cystic lesion I showed you guys was a patient with metastatic liposarcoma of the gluteal region that presented with enlarging cystic lesions. Some of them, the larger ones, contained fluid levels. And wouldn't you know it, I saw this patient the other day. So this is metastatic angiosarcoma, which is certainly in the classic differential diagnosis list for cystic lesions, as well as...
Howard, do you think the ground glass could be hemorrhage from this vascular lesion?
Yeah, that's what we always think of, don't we, when you see angiosarcomas. Look at that interesting ground glass right there. I'm not sure I see a lesion there.
I was wondering that's part of the tumor and not necessarily acute hemorrhage, because sometimes you'll see them all look like this, or they're like that on multiple studies, and it's just the little vascular channels that grow from the tumor that aren't dense enough to cause a nodule.
Yeah, there is a little ground glass opacity there, just a little before on the previous exam. But a very classic presentation of sarcoma, cystic lesions, and secondary spontaneous pneumothorax. The last one I'll show you is interesting from the point of view of the imaging pattern, as well as the fact that I have open lung biopsy report to show you. So in thinking about how one might describe and classify this interstitial fibrosing lung disorder, let me make this big. Let's see what we have. So we have bilateral parenchymal reticulation. It is relatively sparse in the peripheral lungs. As we go down, we see that it's about the same in the lower lung zones as the upper lung zones. So this isn't a basal predominant disease distribution. We do not see in the peripheral lungs foci of subpleural traction broncholectasis or honeycombing. And there are a few regions, let me see if I can pick them out, where one can infer that there is some fibrosis about bronchovascular bundles away from the pleural surface. So let me see if I can find a better one to show you that finding more recently. So this is from October of this year. It has progressed a bit over time. So as we scroll through this, I think that I'll be able to show you in areas like this that there are foci of fibrosis about bronchovascular bundles, and we're starting to see the development of traction bronchiectasis away from the pleural surfaces. And even over time, we don't see progression of subpleural disease. Down here, I think we can describe that there are lobules that are relatively uninvolved, and we'll think about possibly air trapping, lobular air trapping for some of those. Let's look at a couple expiration images. There's a little bit of lobular air trapping there, and a little bit lower down, there are a few foci of lobular air trapping. So certainly in terms of pattern, this isn't a typical UIP pattern. Anytime one sees fibrosis in relation to bronchovascular bundles, one should think of chronic hypersensitivity pneumonitis as a potentially better explanation than UIP of IPF. And this, sure enough, on pathology has a really nice description of the pathological findings one will see with chronic hypersensitivity pneumonitis. So we have airway-centered fibrosis. Airways show some remodeling. There are some loose interstitial granulomas, more advanced fibrosis, but airway-centered inflammation. So I think a very nice correspondence between the pathological findings and description and what we see on imaging as well. It goes along, I think, very nicely, a nice correlation. I don't know that the antigen is known in this person, but I presume Jeff and Dave would agree. David would agree that this is a nice chronic hypersensitivity pneumonitis.
Absolutely.
Yep.
Have you guys
imaging pattern?
Have you guys heard of a bird called a sun conure? C-O-N-U-R-E. Sun as in, the sun that the Earth revolves around. I've never heard of sun conure before.
Nope.
Nope.
Okay. Well, we have a case of HP to a sun conure that lived in the patient's bedroom, and the wife reluctantly got rid of the bird with tears, gave it to a friend who, and we'll be following the friend for hypersensitivity pneumonitis. But it was sort of a close contest between dumping the husband or dumping the bird, I think.
Very nice.
Can I make a point about a case that I showed last week? I showed a case of a localized dilation of the coronary sinus, and we were calling it a coronary sinus aneurysm. The person had pulmonary hypertension, and since I showed it last week, the biopsy has come back. And despite the fact that the lungs were pretty clear, and I didn't see anything that looked like plexiform arteriopathy or any other sort of ground glass abnormality, the diagnosis is surprisingly pulmonary capillary hemangiomatosis. So that case is actually more interesting than just the finding of the coronary sinus dilation, that little aneurysm thing. It's actually a case of PCH, despite the fact that there's nothing distinctive on the radiology about it. So you might want to take another look at that. Just file it away as that's the first time I've seen PCH without actually more dramatic ground glass findings on the CT scan.
Very interesting.
Okay, I have to go look at that again, because you figure you would need enough abnormalities to actually cause pulmonary hypertension.
And they also said that there was no indication of VOD, which is often accompanies PCH. So there was not veno-occlusive disease. So, and they specifically said there was no plexiform arteriopathy. So they really nailed this as a pure PCH. So I was very surprised.
Yeah, me too.
It is curious. You always sometimes wonder about so-called sampling error. Did they really get pathology that's in the lungs in a case like that? It's always hard to know, isn't it?
Well, if you guys see anything on the CT, if you still have the case to look at, let me know, because I couldn't find anything that was distinctive for either VOD or PCH.
Okay. All right, guys. Thank you, and I'll talk to you next week.
Thanks, everyone.
Bye.
Bye.
Bye.